In chapter 3, we'll start to talk about healthcare information systems, or HCIS, is typically the acronym that we'll pair with that. So we'll start to talk about the difference between and the types of administrative versus clinical information systems. We'll talk briefly about the evolution, what we expect those systems to do. Talk about, kind of a fairly recent advancement around the use of personal health records, or PHRs, and then also patient portals, and then again kind of revisit things like interoperability. With that is also things like safety, and then the role usability play. So this is kind of the key things that we'll kind of go through today. But it's worthwhile to just real quickly kind of lay the map out in terms of what are some of those key acronyms. And this is where healthcare IT gets a little bit challenging for those of you that are maybe taking this class just as an elective. Maybe you don't have any exposure to healthcare and or technology. That's okay. Some of you might come into this class with a healthcare, like a clinical role. I've had several clinicians in this class, doctors, nurses, techs, the like. Some of you might be coming in from a strictly technical standpoint. With healthcare, we're taking healthcare acronyms, we're taking IT acronyms, and we're merging them all together in this just alphabet soup, if you will. And I'll argue the only time this gets any more complicated is towards the end of my time working with Cerner. I got put on a government project with the Department of Defense. And of course, the military, the Department of Defense, has their own series of acronyms as well. So we spent, the first 6 months of the project, it was pretty commonplace every meeting to just be sure everyone understood the acronyms that were getting used. So worthwhile. I try in this class to be sure I define all of those. If there's ever a time when I don't, please don't be at all shy about reaching out to me. It's not intentional by any means, but I'm happy to help clear some of that up. Some of these have been used for so long that the text might not always do the best job of defining them as well. So don't hesitate to let me know. I think the important thing here when we start to talk about health IT systems is that they divide pretty clearly into two categories, if you will. And where the evolution started is on the administrative side, as I said in a prior lecture. Things like your billing systems, your payment systems, some of your collection systems, those all fit into the administrative side. Then the clinical side, that's your EHR system, of course, your what they call CPOE, computerized physician order entry or provider order entry, med administration, decision support, all of those things. Now, here's the important thing to keep in mind. Some of your large enterprise HIT providers, such as Meditech, Cerner, Epic, McKesson, they have offerings in both of these columns, right? So the Epic Enterprise does administrative type stuff as well as clinical. So does Cerner, so does Meditech. McKesson does some of that as well. So it's not always clear cut in one camp or the other. Oftentimes it's kind of a blurring of both, right? So if we talk about and lay over the top of this where IT was and where healthcare was, we go back to the 60s and 70s, very mainframe. Only our largest big money hospitals, also more specifically your academic teaching hospitals that had access to grant funding and some of that, were the ones using any type of computer systems at all. But again, it was mainframe based. It was what we called green screen. Windows didn't exist. The mouse really didn't exist. Some of it was maybe done, with a light pen in the late 70s. But it still required a pretty specific skill set to even be able to use these systems. It wasn't as simple as just being able to put a keyboard in front of a nurse and say, here, do this. Okay. In the 80s, we saw the growing need for more clinical and administrative data, and the microcomputer came along. Now, it's worthwhile to note, while the microcomputer did come along, it was ridiculously expensive. They were enormous in size. They were still very difficult to use, and the storage capabilities were a joke compared to what we have today. But that's where we were. 90s came along, and here comes the World Wide Web, the internet, email, all of this stuff. If you remember from a prior lecture, this is also when the Institute of Medicine shows up. Okay, so widespread adoption of all of this stuff. There's an emphasis on moving to a computerized health record, an EHR, if you will. Okay, now is what's happening is a lot of vendors that work in the technology space are going, wait a minute, there's a need here, and most importantly, we can make some money. So how do we get on board? Get into the 2000s, again, the IOM comes out, as I mentioned in a previous lecture, talking about patient safety. We start to talk about the Leapfrog Act was talking about the importance of CPOE, computerized physician order entry, or computerized provider order entry. And again, the idea behind this is simply, in the days of old, a doctor would come to the nurse and say, give me 500 milligrams of acetaminophen, 5 milligrams of lisinopril, order a chest x-ray, and let's also get a CBC. It was then on the nurse to either write that down and send it down to the lab, to the pharmacy, to radiology. In the old days, that was sometimes done via vacuum tube system in the hospital. After that, the nurse might enter it into a computer. Sometimes it was done via faxing it to another department in the hospital. But in the 2000s, we said, no, doctors, you need to enter in your own orders. As you might imagine, this was hit with great resistance, and to this day is still hit with a great degree of resistance. I will say that statistically, most of your doctors that have come out of med school within the last 10 to 15 years are a lot more accepting of this because they had to do it in med school. The ones that are still launching a pretty firm resistance are physicians that have been in practice for over 20 years. Okay. In the early 2000s, your first kind of offerings of PHRs, personal health records, came along. Adoption was not very good because they weren't extremely usable. But then you got into 2010 up to where we are today. You had things as, again, we mentioned this in a prior lecture, the Affordable Care Act, incentive-based programs from Medicare, Medicaid services, CMS, around if health systems adopt technology and show that they use it in a meaningful way, they can get cash payments from the federal government. And that was widely successful. Continue to talk about payment reform, yet more emphasis on population health and population health management. We start to look and realize that healthcare is yet again a treasure trove of data that we can use to make better informed decisions. Okay, cloud computing becomes incredibly prevalent. I remember in 2010, I was at a conference and they were going to talk about cloud computing for the first time. And they had brought in an expert from Amazon and somewhere else, I can't remember. And this was a huge, huge lecture hall at a big conference exhibition hall. And the fire marshal actually had to lock the door and ban more people from coming in because so many people wanted to hear about this new thing, cloud computing. And then, of course, an increasing need of mobile application, right? Anymore, especially in the retail consumer sector, if you can't do something via your smartphone, studies show that a lot of people just simply won't do it. So being able to do things from a mobile standpoint has continued to grow in not only popularity, but frankly, need and demand. Okay? Why do we have an EHR? Well, a lot of reasons. It allows us to electronically collect and store that patient data. It hopefully allows us to supply and communicate information to our various providers that are involved in our span of care. Allows the provider to directly enter orders via the CPOE system. And then also advise the other practitioners, other providers that are involved in our scope of care, if you will. Most likely by now, you've all interacted with at least a patient portal in your lifetime. And again, this is a way, depending on the amount of feature and functionality that your given provider has turned on, you might be able to simply just pay your bill. The more robust ones will allow you to do all of the things you see on the screen here, right? You can communicate with your provider electronically. You can book your appointments. You can ask for refills. You can read all of your results, look at your care plans. I know me being a little bit of kind of a numbers geek. I like to every year after my physical log back into my portal, and I can see a chart that shows my vitals. It shows my labs over the 10 years that I've seen the provider, and I can see all that stuff. So huge benefit to the patient. And if done correctly, this is a huge benefit to the provider, right? So I could talk about this for quite a while, but I think one example I'll call out is something as simple as scheduling appointments, right? So if I schedule an appointment through a portal, that requires very little human interaction, if any at all, on the side of the provider, right? Whereas if I don't allow patients to schedule via the portal, how do they do it? They have to call, right? So I have to have somebody on the phone at the office that answers the phone, has the technical aptitude to work with the scheduling software and schedule the appointment. Okay. So it's really easy to start to assess the ROI behind this, right? And not to oversimplify, but if I have a front office clerk, and pick your job title, if you will, but whoever's answering that phone to schedule appointments, I have to pay that person. I have to give them lunch breaks. I have to give them benefits, insurance, vacation time. I have to provide a place for them to sit. With that comes risk. Could they click on the wrong thing? Could they breach data? Any number of things. Okay. If I allow the patient to schedule online via the portal, almost all that goes away, doesn't it? So now I'm not paying a salary to that person, or I repurpose that person to do something else that adds more value to the organization. So it's real easy to kind of quickly calculate that ROI, if you will. Now, I'm going to caveat this and say this is not all wine and roses when we talk about a patient portal. You give the patients the ability to communicate with a provider whenever they want. Physicians start to complain that their inbox quickly becomes overwhelmed with questions from the patients. Okay? So it does come with sometimes it struggles as well. PHRs, or personal health records. These can be very, very simplistic. A personal health record, by true definition, could be something as simple as a Fitbit that I wear. And maybe you use your Fitbit in the most simplistic of form, and you just track how many steps you take a day. Some of you might use more robust versions or features and functionalities of your wearable device, like your Apple Watch, that can track your sleep data. It can perform an ECG. It can tell you your O2 sat. It can track your resting heart rate. It can track your heart rate while you exercise. Okay. If you're using full-blown integrated, the Apple Health Kit, you can also start to punch in your dietary. Some people will actually get a Bluetooth-enabled scale, a Bluetooth-enabled blood pressure cuff, and they'll start to track some of those other vital signs and log those into their personal health record. It can be very robust. Okay? The big definition, what distinguishes a personal health record versus an electronic health record, is ultimately who holds that data. And I'll say that the textbook doesn't do the best job of defining this. So this is why I spend a little bit of time talking about it. If you hold the data, if you, the person / patient, hold the data, then it is a personal health record. Many of your EHRs that have a very robust portal will enable you to be able to go in and enter things like your exercise and your dietary and all of that. But who holds that data? It is the provider, it's not you. And that's the fundamental difference. We talk about adoption of EHRs. In 2015, they said it was at roughly 84%. That number continues to grow. I would argue it's up over 90% now, closer to probably 95. Okay. Adoption rates for the specialty hospitals are a little bit lower, but they still continue to make progress. A large amount of our primary care surgical specialties have also adopted them. That continues to grow as well. What's the driving factor here? Reimbursement. If I don't submit electronically, a lot of these payers are saying, I'm not going to pay you. So it's out of necessity. We follow the money. But why do I do it? Quality, outcome, safety, efficiency. I can improve my revenue. Plotting this to ROI is very easy to do. If done correctly, our providers, our caregivers can be far more satisfied. If we do it poorly, I have had physicians stand in my face and yell and scream because it's so bad. Same thing with the patients. If the system is not functioning properly, if it's not configured properly, and if we didn't train our users properly, they can become very angry with us as well and reduce that satisfaction. But if done correctly, this all works and we see these benefits. You can see ROI on a system. It's a very clear business case to make the spend. I've talked a little bit about interoperability in a prior lecture, and this just kind of rehashes it. The only thing I'll add here is the ONC, which remember is the Office for the National Coordinator, has created a roadmap and said, here's what we're going to go do. I'll tell you, the roadmap is already out of date. We're just not making the progress we need there. And frankly, I'm not sure when we will. The Fed is trying, but we still have a long ways to go. Last, I'll talk about usability. And this is something that, quite frankly, in the early 2000s got virtually no attention. And the textbook really doesn't touch on this, but if you want to know what really got attention to usability, quite frankly, it was the launch of the iPhone. When Apple came along with the iPhone, it was incredibly user-friendly. That was their pinnacle of launching this. Was it was just so natural, it was easy. It didn't have a lot of things that were confusing. It required virtually little training to use. At that point, it resulted in really an outcry in the tech space of why aren't more things more simplistic to use? So probably the vendor leading the way in this space would be Epic. They tend to get the highest scores for the most usable system. And that frankly has provided a big wake-up call to some of the other big players in the space. Cerner has been working on it. The Department of Defense, the VA projects undergoing, they were previously on a system that was called Vista A, and it was very poor, very unusable. They're bringing in Cerner in hopes that becomes more usable. The other one that typically gets fairly low scores on usability is Meditech. Meditech, which is used across the HCA landscape, typically doesn't score very well. Okay. Also, things specific to safety. In a perfect world, a well-functioning EHR will alert us to adverse events, things like medication administering a med that the patient is allergic to, a medication that the patient maybe already received, the text cites unsafe conditions. So for example, if you have a documented drug allergy to penicillin and the provider doesn't see it and tries to prescribe you penicillin, the system will alert them and say, hey, you can't do this, okay? Or you shouldn't do this. The other thing it does is stuff like weight-based dosing. It'll help the provider ensure that they're giving the right dose to a patient. So, and the text talks about some other things as well. But again, just kind of being that second set of eyes for the clinician, not taking over, but just helping ensure they get what they need. So again, so we talked about kind of the big differences between administrative and clinical systems, talked about the history of HCIS, introduced the EHR versus the PHR, and talked about the impact of those patient portals. A little bit of emphasis on the adoption rates. We've come a long way there. And then the value that they add, and then some of the problems we continue to face. So, again, top three: interoperability, usability, and health IT safety. So that concludes everything for this chapter. And let me know if you have any questions.